we have another interesting lecture which is coming up on regarding the hypertension. This is renal artery stenting. So Dr. I. Satya Murthy from Apollo will be speaking, delivering this talk. Dr. Satya Murthy, please. Here.
Chairman, ladies and gentlemen, at the outset I would like to thank the CARE group for giving me this opportunity to be here this afternoon. My talk is on renal artery stenting, indications and overview. Most of you must be doing renal artery stenting. And when we talk about hypertension, renovascular hypertension, basically we are dealing with three things. One is atherosclerotic renal artery disease. Second is fibromuscular dysplasia. Third is aortoarteritis. To add to this, now a new system has come, new phenomena has come called post-transplant renal artery stenosis. The prevalence of atherosclerotic renal artery stenosis, which is the biggest chunk of renovascular hypertension, is atherosclerotic renovascular disease. It all depends upon what type of population you are picking up. In general population, it is with hypertension 2 to 5%. If you take diastolic hypertension more than 100, that is 53%. It depends. If you are taking the end-stage renal disease or those who are on dialysis or a Medicare population, it is said that above the age of 75 years, about 6.8% is detected by Doppler. We published data in 2007 in JAPI that those patients who are having severe coronary artery disease, either single vessel or triple vessel, will have an incidence of about 7.7% when we do drive-by renal angiogram. The indications for renal stenting is patients should have hemodynamically significant renal artery stenosis with uncontrolled hypertension, patients having ischemic nephropathy, cardiac disturbance syndrome like flash pulmonary edema, uncontrolled heart failure or angina. Hemodynamically significant, which I will be talking very soon. Uncontrolled hypertension, basically they are unable to be controlled despite of at least minimum of 3 drugs with maximum dosage, maximum tolerable dosage. When once you do renal stenting, usually BP response is seen within 48 hours as reported from various series. The response is categorized as completely cured, which is seen in very minimum, very less percentage of patients. Majority of them show improvement as regards reduction of BP as well as number of drugs required, or there may not be any change or worsening. If you can achieve BP control below 140/90 or 15% reduction in diastolic blood pressure with at least 2 drugs, that is enough to show that your therapy has been effective. It is known that majority of the centers are able to achieve 98 to 100% of improvement in the anatomical result or angiographic result after renal angioplasty. But after doing this, how many patients you are able to control the blood pressure? That is the issue. If you take atherosclerotic renal artery stenosis, the number of patients who show cure is very minimal, that is only 10%, and about 52% will show improvement. So only about 2/3 of the patients either show cure or improvement as reported from various series. But this is not the case with fibromuscular dysplasia, where usually it is bilateral and they respond very well to even plain balloon angioplasty. Sometimes they need stenting. Here the percentage is almost 80%, either cure or improvement is seen in almost 86% of patients. But my talk mostly on atherosclerotic renal artery stenosis. The first reported series is at NEJM in 2000 called DRASTIC trial. It has really changed drastically the outlook about the procedure. But if you see correctly, only 56% of patients were given stent, 50% of patients were on optimal medical treatment. Half of them were converted into angioplasty. In 2000, stenting was not common, and majority of them undergone plain balloon angioplasty. Only surprise was that it was published in NEJM, so many of the nephrologists started criticizing this procedure. Then came in 2002, multi-center PTRA renal angioplasty registry data by Doros et al. In 2002. They have got 1,058 patients, 4 years follow-up. They found significant reduction in the systolic as well as diastolic pressures, reduction in the antihypertensive medications, and also improvement in the renal function. In patients with bilateral renal artery stenosis, have got significant improvement compared to unilateral renal artery stenosis when they are stented. Then came ASPIRE 2 study published in JACC 2005, where patients who have got unsuccessful plain balloon angioplasty for osteal and restenotic lesions were only given stents. Otherwise, they had plain balloon angioplasty. In this group also, there is significant reduction of both systolic and diastolic blood pressures in 40% of cases at 2 years follow-up. Then came STAR trial, published in Annals of Internal Medicine 2009. It is a Dutch study. They picked up cases by CT angiogram. 76 patients have undergone best medical treatment and 64 patients were chosen for renal stenting. Out of these 64, 18 patients were not given stent because they found the stenosis is not significant. That showed that CT angiogram is not really accurate in detection of the renal artery stenosis. They found no significant difference in endpoints like clinical events, serum creatinine, blood pressure levels, and number of antihypertensive drugs. Then came a large trial published in NEJM called Astral trial. 403 patients in each group, the percutaneous renal angioplasty with best medical treatment versus best medical treatment. There was a big criticism because 41% of patients, the stenosis was less than 70% renal artery stenosis. The pressure gradients were not measured. Unilateral renal artery stenosis, 25% of patients had normal renal function and 15% of patients had mild impairment. 6% of patients with best medical treatment crossed out to stent. 17% of patients with stenting group did not receive stents and complication rate was 1 in 5, 19%. There is no core laboratory. 65% of participating centers randomized only one patient. So this trial was debated extensively in various review articles. From various studies, I picked up some parameters or variables. The BP control depends upon bilateral versus unilateral, duration of hypertension, angiographic success, diabetes, elderly age group, atherosclerosis in other vascular territories, serum creatinine levels at the time of stenting, size of kidney by ultrasound, and intrarenal resistance index. Of all these, I find the last two are very practicable and we can really use in our laboratory. Last two things, we can do an ultrasound and find whether kidney size is normal or small. In our laboratory, if the renal resistant, of late we started choosing patients. If renal resistant index is more than 80, they are non-responders. We are not accepting those patients for renal stenting, either unilateral or bilateral. We are looking at the literature, so much of variability in the results, which we have chosen out of 380 patients, 80 patients who have undergone renal stenting from January 2004 to 2007 to assess only BP control. The nature of stenosis can be unilateral or bilateral, and the type of stent, associated renal and cardiac disorders, drugs during admission and at discharge, and 12 months follow-up we have assessed. Unilateral were 47, bilateral were 33. Their age group was 38 to 80 years. 41 patients were above the age of 65 years. There are more men, 57 versus 23 women. All these cases were done by guiding catheter technique, and majority were femoral route, 3 were radial and 3 had brachial route because we couldn't get radial in those, with the catheter could not reach the renal arteries, so they were taken for brachial route. As I said, all patients had severe hypertension and they have got severe renal artery stenosis. Those patients who are on dialysis or who are normotensive despite of renal artery stenosis, whose serum creatinine more than 2.5 milligrams, patients having significant proteinuria suggesting that there is nephropathy, or those who had complications after PTRA like any thrombosis or slow flow phenomena, they were excluded because you can't assess these patients at the end of 1 year whether hypertension is being controlled or not. We have followed AHA expert panel recommendation. There should be at least a minimum of 20 millimeter systolic gradient, and a mean gradient should be at least 10 millimeters across the stenotic segment. We followed these patients for 1 year for BP levels, serum creatinine, number of antihypertensive drugs, and dosages. And patency of the stent was confirmed at the end of 6 months and 1 year by Doppler. Majority of them didn't turn up at 6 months, that is, and definitely by 1 year, and these patients had patent stent by Doppler. We found that there is a significant reduction in the systolic blood pressure as well as diastolic blood pressure, but there is no significant difference at baseline as 1 year as regards the serum creatinine levels, and definitely there is reduction in the number of antihypertensive drugs in these patients, and very difficult to assess the dosage of drugs, so we have not taken that parameter variable at the end of 1 year, because very difficult to say. You may increase calcium blockers, you may reduce ARBs, so it's very difficult to assess individual drug. We have got only 3 patients for total cure, that comes to about 4%. The reduction in the number of drugs were about seen in 37% of patients. Reduction in dosage of individual drugs in 13% of patients. Change of drugs, for the whole group of the drug was changed in 20% of cases. Maintained on the same dosage in 20%. About 4 patients, that about 5% of patients worsened and needed more drugs. We compared our data with the various various reports from the literature. We found our data is in agreement with majority except one study which showed, published in 2000, about 38% of their patients showed improvement, which we could not really, not that one, the last but one, Stephanidas, 58 patients, this one, showed about 35% of patients showing cure, which is really remarkable and cannot be explained how it can be so much of high cure rate in these patients. The limitations of our present study is a retrospective analysis. It is a univariate analysis. We have only seen hypertension. Multiple operators, each operator will have his own way of assessing using the contrast, and we have not used any distal protection devices. There are 3 ongoing trials: the CORAL trial, cardiovascular outcomes in renal atherosclerotic lesions; RADA trial, randomized multicenter prospective study comparing medical treatment versus renal stenting; NITER trial, where nephropathy ischemic therapy. These 3 trials are ongoing, and I am definite that CORAL trial really will show some light and direction regarding the long-term benefits of this renal stenting. This is a case where there is a bilateral renal artery stenosis, 1 by 1 renal artery was stented, and final result. This is a case of bilateral renal artery stenosis, one side renal artery was totally occluded, and here, and it is almost like a single functioning kidney with tight renal artery stenosis. So to conclude, renal stenting for atherosclerotic renal artery stenosis benefits the following: those who are having more than 70% renal artery stenosis by angio, unilateral or bilateral or solitary kidney; those who are having rapidly declining renal functions, unilateral renal artery stenosis, who has got severe hypertension with renal insufficiency. The rate of decline of renal function is the strongest predictor of benefit by stenting. So if you are seeing sequentially these patients following up, if there is worsening in the renal function, that group will, last 2 slides. The renal stenting does not benefit unilateral renal artery stenosis with normal or stable renal function, whose BP could be controlled easily. Those with small size kidneys, those with significant proteinuria, those with very high risk of atheroembolism because of diffuse atherosclerosis of the descending abdominal aorta. Renal artery stenting is a well accepted therapeutic procedure for carefully selected patients of renal artery stenosis with severe hypertension with or without renal insufficiency. However, there is minor risk of atheroembolism which can adversely affect the outcome. Thank you very much for your kind attention.